what is a practice after integration, and I think that's a great topic, and I think it's the main issue that physicians are confronting today. But really it's a very simple answer. The issue of what the practice looks like before integration should be no different than after integration. Physicians are really worried right now how they are going to relate to the hospital. That is not the issue at all. The issue is how do the physicians relate to themselves. Internal governance is really going to be the biggest challenge physicians face. Physicians tend to be independent people that don't work together well as a team, and as we go forward to provide higher quality and lower cost care, you're going to have to work as a team. You're going to have advanced specialty care, going to have to share responsibilities and give up some responsibilities. The hospital systems really don't want to be involved in that. If you're a hospital CEO and you have a very, very functional, well-run group that works together, the interaction is very simple. You sit down with the CEO of the group, you go over the budget, find out what you need, and you go forward. So what I see the focus now, and most groups are worried, gee, is the hospital CEO going to tell me what to do? Yet when you talk to the hospital CEOs, what they're worried about is what's going on in the group. If you're a hospital CEO and you integrate with a 20-person cardiology group, you want to be sure that you're not going to have 20 cardiologists come knocking on your door every time there's a problem. It's their worst nightmare. That's one of the reasons they don't want to integrate. Some of the CEOs are being even a little bit more sophisticated. They're demanding, as part of the integration deal, that compensation models have been worked out, and they're even demanding governance consultants come in. They do not want to be in the physician management business. They did that years ago and it was a disaster. So how does it work after integration? It should work the same as before integration. The only advantage I think for physicians is, at least in our group now, we can really practice medicine. We're really focusing on quality initiatives, outcome analysis, data systems. The struggle with private practice was Medicare was 60% of our business, and we just couldn't rely month to month even on what our fees were going to be, and you can't plan quality programs if you keep getting slashed by 1,000 paper cuts. So long answer to a short question, but it's simply put, how do you get along now is really how are you going to get along after integration. Well, first of all, effective leadership doesn't mean you could read an echo, read a nuclear study, or put in a stent. It's a totally different skill set. And just like you, in a way, get board certification in your technical skills as a physician, you need formal training in leadership. Leadership of a physician group is no different than leadership of any company. Human dynamics are human dynamics. Organizational structures are similar, and there's a lot of good baselines for that in the business world. So the first thing people have to understand that it is a separate skill set. Leadership does not mean the most popular person in the group becomes a leader. And leadership has to be professional. The old model of people getting together 8 o'clock at night when all the work is done to meet to solve problems isn't going to fly anymore. The people who do leadership need to have time to do it effectively and need to be compensated for it. Otherwise, you're going to get what you put into it. If you put nothing into it, you don't put resources to train your leaders, you don't do succession planning, you don't have accountability put into place, and you don't have professional leadership, what you're going to get is no leadership. It gets back to leadership, and I'll give you just a great example. So we are currently in our group using an EMR platform that has been abandoned by the manufacturer, and we're going to go to a new EMR platform, but it'll take about a year to get in place. However, our current template for history and physicals is not adequate. We don't feel it's producing the work product that we would like. So we put together a group of physicians who were volunteers. It was open to every physician in the group to look at how we produce our clinical note. Those physicians were compensated for their time, and they met every week for 4 months. And they came up with a decision that despite the hardship of switching templates, which is, again, once you switch a template, you have to learn a whole new way of pointing and clicking. They felt that for quality metrics, for better referring physician satisfaction, for ease of covering your partners on calls so you know what in fact happened the last time the patient saw your physician, we had to make this switch, even though it's going to be for 1 year, and then after that we have to switch again. Now there's some blowback because a lot of the physicians in the group say, Well, why do we have to do that? I mean, why can't we do it the old way? Wouldn't it be easier? But see, the beauty of the leadership here is this was a volunteer group of their peers, which spent time. And when the group came around, they said, you know, these people really put time and effort into it. We assume they're intelligent individuals. This was their decision. We have to honor it. Now, we'll be accountable. We'll see once we do the switch to the new template if it really is functional. We know that it is because we tested it before we rolled it out. But as you go forward is going to be change. To be accountable, there's going to be change. You're going to be telling people you have to do something they don't like necessarily, and that is standardize. Physicians don't like to standardize. You can't have separate order sets for every interventional physician. If you're going to be doing stents, you have to do a certain number to stay proficient. If you're going to read echoes, you need to do a certain number. And also the people who overread need to overread and give you real-time feedback. Sometimes that's difficult because physicians are not good at taking constructive feedback. We have a chart audit committee. My charts are audited, and they will come to me and say, Matt, you're a good doctor, we know that, but you're not, the flavor of what you're doing for the patient is not coming out. The whole nature of accountable care means you have to be accountable. And that's the problem. Physicians will be accountable until they're held accountable. Once they're the ones being held accountable, it's a different story. So that's going to be the real struggle is how do you enforce the rules? And it's going to be standardization and subspecialization. You can't have someone do 40 stents and then someone else do 300. You can't. Yeah, you might tell the person who's doing 40, look, this is time, there's not enough work here for you to maintain your level of skill. And that's going to create difficulties. And a lot of physicians are not going to tolerate that. But then they'll never get, they won't have as good a product. Well, it all depends on what your philosophy is. We started discussing integration in April of 2008, well before any of the fee schedules were out there. Now, I had no idea that the fee schedule would come out. I really didn't. The reason we started the discussion was we knew that if we were going to be a quality group, we needed stable revenue, stable, not necessarily increasing, but stable for us to invest in the future to provide the quality we wanted. So that was the reason we integrated. Now the fact is that the floor fell out from cardiology. Turns out we were lucky in terms of the timing. But I guess I would say to the group, what are you really looking for? Some folks just want to practice, and so that might be a model where they might do better off in a university setting, or they might be better in a giant HMO. I really have to make sure that the people that are working together share a common vision, because if you don't, then you're never, there'll never be happiness. And once you integrate, people will leave. And I think it's important for groups to understand that in most integrations that will happen, 15% of the physicians end up quitting. And the physician leaders are not the happiness police. So in a nutshell, what is the group's vision? What do you all want to do in the future? You know, what are your age ranges? What opportunities do you have with the local hospitals? What do you all want to do? Are you all going to stay together? And then once you sort of have a common understanding of what you all want to do, then you can make the next step. But it can't just be, I want a paycheck that's higher than the one I'm getting now. Because at the end of the day, you'll be absolutely miserable if that's what you do, miserable, and end up quitting anyway.